Yes, you can go ahead.
Shall I, Neeraj?
Yes, sir. Yes, sir. You can go ahead, sir.
Yeah, sure. Good evening, everyone. Can you all hear me?
Yes, sir.
Very clear, sir.
Good evening, everyone. Welcome to this unique module of Fellowship on Osteoarticular Infections. During my undergraduate days, a very famous book on surgery carried this saying: you can spit an abdomen, nothing happens. But even if you say hello to the bone, it gets infected. To which we students had added this line: once infected, always infected. Because we are really scared of that osteoarticular infections. Those days we had hoped that by the time we become postgraduates and practicing people, conditions will improve. And especially in last few years, we had really hoped that with improved diagnostics, better surgical procedures, better understanding, and better antimicrobials, the condition would improve. Unfortunately, we have not achieved that. There are two main reasons. One is, of course, epidemic of comorbidities like diabetes, and second and most important is the guerrilla tactics by microbes or biofilms, which are actually safe abroad for microbes, challenges for us, the medical professions, and actually disasters for the patient. Remember, yesteryears, microbes used to obey us. Today, they defy us. We have to change our policies as per the fancies and whims of microbes. And therefore, we have to change our policies and tactics to deal with this situation. With that idea in mind, we have started this program, Fellowship in Osteoarticular Infections, how we learn and we are still learning. We have a galaxy of faculty. The first and foremost is my mentor, Dr. A.J. Thakur. You must have read most of his books. They are like Bibles for postgraduate students. And he says that a man is, we used to say that a man is known by the company, while he says no, by his books. So everything that I would be speaking or Dr. Aditya would be speaking has actually goes through or under the watchful eyes of Dr. Thakur. Dr. Aditya Menon, who is a junior consultant at Hinduja Hospital and has been with us for last 6 or 7 years, mainly dealing with infection. And he is in fact country secretary or country delegate for India for European Bone and Joint Society. He is also an honorary secretary, infection section of Asia Pacific Orthopaedic Association, and he has done fellowships at several places. He has been a faculty at several international and national conferences, mainly on infections, and he has several publications to his credit. I also would be mentoring you. Two main things I would inform you that I had done a survey or research project on osteoarticular tuberculosis in 2004 to spanning almost 10 years or so for Bombay Orthopaedic Society, and it was awarded Golden Jubilee Oration of 2019 IOCON, and that is supposedly the highest award for original research done in India. And I have been basically doing work on infections for the last several years. At the outset, I sincerely thank my orthopedic colleagues, my plastic surgery friends, our microbiologists, our infectious disease specialists, and many of them would be guest faculty over next 8 weeks. The fellowship has 8 modules, as you all know, covered over 8 weekends. There are certain caveats I would like to inform. These cases we would be discussing over next 8 weeks are rather intellectual property of the faculty members, and in case you want to present them anywhere, you should take consent from these faculty members. Whatever we would be presenting is for academic purposes and cannot be used for medical legal reasons. And one of the most important things is several people would be giving opinions. There are bound to be different opinions, and we will respect everybody's opinion. I mean, respecting differences is friendship. With that introduction, let us start with the first module, that is hematogenous osteomyelitis in adults, analysis and decision making. Our friend Harjot had suggested that we also should include pediatric orthopedics, and that is why we have decided to give little more time for pediatric orthopedics. And next week, Dr. Mandar Agashe would spend a good half an hour with you all for pediatric orthopedics. Now, let me start with the first case, and I always like to start with the case where you can say case from the closet, or how I could have treated this case differently. So in short, for all you, learning from my problems is much better than learning from your own problems. So this was a middle-aged person presented to me about 8 years ago with severe pain in the left thigh for 3 weeks. He had fever for 2 to 3 weeks. So when he approached us, he had significant swelling in the thigh. You can see it is absolutely visible. There was also a biopsy mark, and you all have gone through this case history and also opined. So I will not really go into details of all this. The X-ray was suggestive of periosteal reaction. MRI was reported as malignant tumor. The orthopedic surgeon, the oncosurgeon, did a biopsy which showed SSA infection, and therefore the MRI was reviewed. The radiologist said, no, I think I agree that this is infective lesion. And this, for me, it fitted into acute osteomyelitis because this was a recent bone infection that causes systemic infection or systemic inflammation. So my question was, this fits into definite or probable or likely osteomyelitis. So a majority, almost everyone said that this is definite osteomyelitis. So how do you define a definite osteomyelitis as per the criteria? So this was a paper published almost 50 years ago. Definite osteomyelitis is when pathogen is isolated from bone or adjacent soft tissues, and or there is a histologic evidence of osteomyelitis. So you have actually cultured the organism. Probable osteomyelitis is when blood culture is positive in a setting of clinical and radiological features of osteomyelitis. So there is an evidence in as regards culture is concerned that a microbe is isolated, though a biopsy is not done, or even if it is done, it did not grow bugs. And lastly, likely osteomyelitis is when there are typical clinical findings with definite radiologic evidence of osteomyelitis and response to antibiotic therapy. That means you diagnose this as a likely osteomyelitis only after treatment, because one of the criteria is response to the line of antibiotic therapy. Now, my second question was, what would be your plan of action? And again, majority said that you would like to explore immediately. Absolutely. You would like to explore immediately. Why would you like to explore? Again, a paper published almost 50 years ago, Ornette's Principles, says that antibiotics are effective before pus forms. Now we have pus form. So there is no way your antibiotics will work. Antibiotics cannot sterilize avascular tissues. They will prevent pus formation once we have already removed the pus. And this removal of pus will restore periosteum and restore the blood supply. And even after surgery, antibiotics should be continued. This was the thinking for 50 years ago, and it still stands true. So obviously, I operated. I took a lateral incision. I excised the biopsy wound. You can see there was a significant granulation tissue here over the lateral cortex. And as I made a drill hole, pus came out. And I made a window. You all have seen this. And you also have seen that he developed a fracture. But as regards the antibiotics are concerned, majority of the people have said that they would give first or second generation antibiotic, cephalosporin, and 30% of you have said that you would give third generation cephalosporin. Some have said they'll give Vanco, some have said linezolid. Dr. Aditya, can you just unmute yourself and tell us what would be your choice of antibiotics?
So Staphylococcus aureus, which is methicillin sensitive, can be treated by simple antibiotics like a first or second generation cephalosporin. So that would be the drug of choice in this case, either a cefazolin or a cefuroxime.
So it is most susceptible to first or second generation antibiotic. The others should be kept as reserve, right?
Yes.
Okay, this is what was started by our ID specialist. First generation given injectable for first 2 weeks, followed by oral for next 4 weeks. Remember, the dose of these antibiotics is different as prophylaxis, and it is much more when you are actually treating infection. It is almost double. So you all know that we have put this. Now, question was, are you happy with whatever I have done? Almost half were happy, and about 10% would have preferred to do a window from condyles to the extent of osteomyelitic process. The entire area would be explored as per about 10%. 1 in 10 said that they would do that. Many said that I would have stabilized him with an antibiotic nail or an external fixator. So this was almost 50% would have preferred fixation in this case. This is him at 2 weeks. This is him at 5 months. And then this is what had happened, right? So going to our questions now, 10% people felt that the window was inadequate. 90% felt that the window was adequate. This is the breakup you all can see. What would be the plan of action? So now going back to the responses, almost half said that they would do a nail, either a regular nail or an antibiotic nail. While many, almost 43% felt that they would not like to do anything without doing an MRI. And rightly so. Even he was symptomatically all right. ESR CRP had not raised, but still in many cases, the parameters may be absolutely normal, but there could be a significant infection inside. Remember, initially, first few weeks, it is difficult to differentiate an active infection after surgery. But at 6 months, the MRI consultant was absolutely confident. And even you can see that there was a, yes, there was a significant remnant of infection. Will you please unmute? Thank you. So there was a significant infection inside. Now, what are our problems? A, there is a recurrence of osteomyelitis. B, I am dealing with a pathological fracture. C, there is an osteomyelitic process from middle third or junction middle third and lower third to the lower end of femur. And most important, it is operated by me. So when you have to deal with your own infections, you're always tremendously stressed. Now, what are my main concerns? A, I have to eliminate the osteomyelitic process. And number two, I have to see to it that the fracture healing occurs. So for elimination of osteomyelitic process, I have to do aggressive debridement and of course appropriate antibiotics as well as local antibiotics. And again, excellent monitoring. As regards fracture healing is concerned, I have more challenges because I have a previous window there with obviously sclerotic edges which may not take part in fracture healing. So what are my options? I have external fixator ring, I do an antibiotic nail or a plate. Several options are there. Everything will have advantages and disadvantages. Whatever I do, I'll have to do bone grafting whether there is going to be a significant defect. Now, again for debridement, I have options. Either I make a large window from middle third or lower third of femur to the condyles, or I go through the fracture site. Again, everything has advantages and disadvantages. If I make a large window, I can do a real thorough debridement, but it would be a very large structural defect in a fracture scenario. That will be very dangerous. I can scrape through the fracture site. I don't have to make additional structural defect, but my debridement may not be as good. Again, stabilization with fixator, possibly less chances of recurrence, but there are definite chances of delayed or non-union and pin tract infection. I stabilize with a nail, more chances of recurrence because I would be doing an intramedullary nailing. And especially the infection is lower down, so my reaming may not be that good. But there are less chances of delayed union or non-union or even pin tract infection. So everything has advantages and disadvantages. So finally, what I decided was I scraped through the fracture site, real aggressive debridement, used the scoops, long scoops of revision THR, and then used an LRS or limb reconstruction system. And to avoid delayed or non-union, I did a non-anatomical but stable reduction so that I have a good bony construct which was taking up a lot of stress. So this is what I did, what is called cortical mismatch. So the bone itself had good stability. We did cement beads. We removed beads at 6 weeks, filled the defect with autogenous graft. This is at 8 months. This is at 30 months post-op. And that's the range of movement, which was unfortunately less than what I had achieved at 5 months. So what are the lessons I learned? First and foremost, in this case, the corner acted as stress riser. But the most important, did the window perform its function? No, the window did not perform its function. The window has to have an adequate debridement, allowing adequate debridement. So the cortical window deserves more attention as regards the location, the size and shape. So the reason for this pathological fracture, this was a fracture through weak bone because the osteomyelitic process continued because of a small cortical window. I had inadequate access to medulla and therefore I had inadequate debridement. And almost 90% felt that I had done an adequate debridement. And that is exactly what I learned through this, learned hard way. My suggestions for the window should be adequate size to do thorough debridement. So I should have made a long, good window. Now, the next question people might ask, as this is an acute osteomyelitis, all you had to do was drain the pus, and that is enough. And that is what we have been doing for ages. This is a 2019 paper. We are very, very important paper, evolving concepts in bone infections, redefining biofilm, redefining acute versus chronic osteomyelitis, and local antibiotic therapy. Something fantastic. And what they say is, yes, we define acute osteomyelitis as recent bone infection that causes systemic inflammation. And chronic osteomyelitis is bone infection of longer duration with minimal systemic symptoms and presence of key pathological features such as lymphocytic infiltrate, myelofibrosis, and reactive new bone formation. This is the definition of chronic osteomyelitis, which is traditionally going on. And there has been tremendous discrepancy as far as time is concerned. When you say chronic osteomyelitis, 4 weeks or 6 weeks or 8 weeks or 6 months, there is no scientific rationale as per these authors. And they say that we recommend that this definition, which has been carried on for years, should be avoided. Basically because there is an extreme patient-to-patient variability. And still important is histological features of acute and chronic osteomyelitis can exist in the same lesion. And therefore, they say that this classification is meaningless. You must treat every osteomyelitis on its own merits. And what is important is think why and where bacteria will persist. And to answer the question of where and why bacteria persist, I come to this very recent paper published few months ago. Mechanism of persistence or mechanism of failure of antibiotic therapy in Staphylococcus osteomyelitis. This is just recently published, and they have described these different mechanisms. A, abscess. B, sequestrum. Yes, we know this. C, and most important, is biofilm formation. And there are other rare mechanisms. Now, we always used to think that biofilm forms mainly in implant-related infections. But what people have realized is it also occurs in two common orthopedic infections, that is chronic osteomyelitis or osteomyelitis and chronic wounds. In fact, normally bacteria are in biofilm only. Whatever cultures we get is when they are in planktonic form. So I have just prepared this for our understanding. Initially, as the bacteria enter the bone, they are in planktonic form. They keep moving and are easily killed by antibiotics, and some get killed by our body's defenses. Now, if the bone is traumatized or the host defenses are poor, then bacteria start sticking to the surface. You can see them sticking to the surface. Then slowly, why slowly? Over a period of hours or days, they start secreting polysaccharide and start getting embedded in this polysaccharide matrix. This goes on increasing, and then the metabolic rate of these bacteria starts going down. There are no inflammatory parameters. They reduce. Your ESR-CRP may become normal. Patient may not have any inflammatory parameter. They start developing pathways for nutrition as shown here, and they have a fantastic abort. Now, in between, the biofilms will break and planktonic bacteria may be there, which will be again killed by our species, and pus starts forming. Now, if you just remove this pus, the real biofilm or the real fortresses of bacteria still remain, as you can see here. I have drained the pus, but the real bacteria ka what you say is the go down still remains inside. So unless you make a good window and really scrape this, the colonies of bacteria will remain inside. So unless you remove the biofilm, even at 2 weeks or 3 weeks, the bacteria will remain inside. They will slowly multiply. They may not produce much problems. ESR CRP will be normal, but it will be a go down of bacteria, and our antibiotics will not be able to kill them. So our window has to be adequate for thorough debridement. Now, question is, how do I make it safe? How do I prevent a fracture? Remember, once we have taken out everything, taken out the bacterial colonies, then the body will start the natural process of building bone. But till that time, I have to see to it that I do not weaken the bone much. And therefore, I have to observe on CT as well as MRI. It is best to go through thinned cortex, include the cloaca, and what is important is avoid stress riser. So the edges should be regular and not irregular. The shape should be elliptical and not rectangular, and the ends should be circular and smooth. Then there are hardly any chances that this would lead to a stress riser and a pathological fracture. I should have combined these two windows and made a good window for an excellent debridement. So to conclude from this case, the size of window determines the completeness of surgical procedure. Shape of the window determines possibility of the fracture. Pathological fracture can be the result of both incomplete debridement and stress riser. And lastly, as regards stabilization is concerned, external fixator for pathological fractures like this may lead to delayed or non-union, and you need to be careful that you get a good cortical support or have a cortical mismatch to increase the surface area and reduce the chances of delayed or non-union if at all use external fixator. Do I have any more cases for supporting this? Yes. I mean, last 6 years, we have been exclusively doing window like this, and touch wood, we have had excellent results as far as prevention of fracture and completeness of the surgical procedure is concerned. Now, if you have any questions, suggestions, comments, controversies, challenges, please put on the chat box. And I request Dr. Aditya to give inputs about MRI and choice of antibiotics. You have already discussed MRI report in osteomyelitis. I will unshare the screen. Aditya, you can share your screen.
Thank you, sir. There was one doubt in the chat box from Dr. Supraja about rationale for attaining non-anatomic stability with X-fix, or was it the maximum reduction that could be attained on table? Is it something deliberate, or was it because of limitations?
Actually, it is absolutely deliberate. Over next 8 weeks, I will show you our strategies of treating fractures or non-unions with external fixator, because you must have heard and experienced that with external fixator, the chances of healing certainly go down. So we try and purposely achieve cortical mismatch. Of course, what is important is not to have rotational malalignment or angular malalignment. Your alignment has to be perfect. And in a case like this, where I have already got a window, I made it a point to nibble the bone in such a way that I get a good bone-to-bone contact and increase the surface area, rather than having a reduction like this, which can slip. I had a reduction like this, so that the bone became very stable. And over next modules, I will show you our planning like this.
Thank you, sir. So in short, in these next few slides, what I will try and do is give an overview of the basic salient MRI findings that we must look for in any osteomyelitis. So the first slide shows us the liquid, that is the bone marrow edema and abscess, whether it is intraosseous and whether it is subperiosteal. So these are all three in the liquid state. Now there are three main modes of interpretation on MRI. One is the T1 weighted, second is the T2, and third is the T1 with contrast. Now, contrast is something that helps delineate an osteomyelitis versus a tumor and helps highlight the infection as well. Now, we must remember that contrast goes only to the areas where there is blood vessel, where there is blood supply. So, any area which does not have blood the contrast will not go there. So, with that in mind, if you look at the T1, which is on the left hand side, all of this, whether it is edema or abscess, is low. A low signal, that means it's dark. Whereas in a T2, anything which is water like edema or abscess is high intensity or it's white. Whereas if you look at the contrast on the right hand side, the edema will be high because there's a blood supply there. The edema comes from capillaries. Whereas the intraosseous abscesses or the subperiosteal abscess, the center is abscess. There is no blood in an abscess, but the surrounding wall of the abscess is tissue where you have blood supply. So the wall gets highlighted. So it's a circle of white color with a black center. So that's called a penumbra sign. So these are classically seen in abscesses or cysts. The next is we look at cloaca, sinus tract, and sequestrum. Now, cloaca are basically openings, they are blind tracts opening from the bone to the soft tissue. The sinus tract is a live tract which is surrounded by tissue, whereas the sequestrum is a dead piece of bone. Now, again on T1, all of these are low intensity, that all of these will look black or dark. Whereas on T2, the cloaca and sinus tract will be high intensity because there's pus there and there is granulation tissue lining the sinus tract. Whereas the sequestrum, even in T2, will be dark because the sequestrum is a dead piece of bone and there are not enough protons to give any signal even in a T2 image. When you look at a T1 with contrast, cloaca will be low, again because there's no blood, it's just a tract from one end to the other. Whereas the sinus tract will have peripheral enhancement because of the granulation lining the sinus tract. And the sequestrum is surrounded by involucrum or tissue. So that the sequestrum itself will be low, but there will be peripheral enhancement. So to highlight these findings in this case, which is a chronic osteomyelitis, which is an osteomyelitis of the distal femur, the white arrow in all these is the edema, whereas the black arrow in the lower part is the abscess. Now this is a T1 image where the edema and the abscess both are low or dark. Whereas this is a T2 image of the same patient, where the edema and abscess both are high intensity and looking white, the edema and abscess both. Now you look at a T1 image with contrast. So wherever there is blood, the contrast will go. So the marrow edema again looks white. Whereas in the lower part, you see the black arrow, which shows the abscess is going to be dark because there's no blood in pus. Whereas the surrounding wall is white or high intense because the contrast does go there. So those are the salient features of osteomyelitis. Now tumor, T1, T2, I haven't gone into those details because they are a little too complex based on whether it's a lipoma or an osteosarcoma. The T1 and T2 images have varied features. But post-contrast, one must remember that a solid tumor will have heterogeneous enhancement because it has various necrotic tissues, it will have vascular sections. So there'll be dark areas, white areas, patchy areas. So that will give you an idea that's just a solid tumor on contrast. Whereas a cystic lesion will act like an abscess, where there'll be a central fluid with no blood with a peripheral enhancement. Now, the most important thing is, in spite of all of these important features which a radiologist would report, there are times that both of these cannot be differentiated. And even if it is diagnosed as a osteomyelitis or a tumor on the MRI, if we are in doubt, we must do a biopsy and send both culture and histopathology. Sending either one can miss out on the other. So if you get a culture negative and don't send a histopathology, we may miss out on a tumor. So sending both on a biopsy is important. And just going into short about the choice of antibiotic, like we said, MSSA, the choice of antibiotic would be a first or second generation cephalosporin. Although it is both a staphylococcus, they're different ball games. For an MRSA, the choice of antibiotic is vancomycin, teicoplanin. We'll go into more details later in the future sessions. So what we must remember or take from this case is vancomycin, teicoplanin, or linezolid are not better for MSSA. In fact, they are inferior to cloxacillin or cefazolin. Simple antibiotics are better for MSSA. Just because we are giving a higher antibiotic like linezolid does not mean it is better. So this is the one take home that we must take regarding antibiotics for an MSSA concern. So I've covered the radiological findings and the drug of choice for this case. So I think Sir will go ahead with the next case now.
Thank you, Aditya.
So there's one more doubt regarding the first case.
Yes.
So that's why Dr. Pranav Mahajan is asking, if we make an elliptical window and apply X-Fix in same setting, will there be higher chance of failure if there is a unicortical hold of pins in distal femur?
Okay, we will discuss it in subsequent cases. That would be better. Yeah. In case the doubt still remains, then we'll come back to that. So I'm going to the next case. This was a 43-year-old gentleman presented to us in toxic state 10 weeks after the onset of symptoms. 10 weeks. 8 weeks after being diagnosed as suffering from osteomyelitis, and 7 weeks after he was operated somewhere else. These were the MRI images, and you can see the size of the window. It was a very, very small window that was made at the lower end. His culture report that he had carried, in fact, there were 2 reports. Both the times the cultures were Acinetobacter baumannii, sensitive to 3rd and 4th generation cephalosporins. And he was sensitive to cephalosporins, but he was resistant to colistin. So he was sensitive to cephalosporin and resistant to colistin, and also aminoglycoside. Now, my question is, does it fit into hierarchy of gram-negative resistance? Can this report be appropriate? Can you guess the microbe? And we are giving you 6 weeks to find this answer. Please answer in either our chat box or in our WhatsApp group. The first person who gives correct answer will get a prize of 1,000 rupees. I know for all you, 1,000 rupees is not much, but this is a token of appreciation. If you can find out the answer to this question, as culture is reported as Acinetobacter, sensitive to 3rd or 4th generation cephalosporin, resistant to colistin. Resistant to colistin. Okay, so we go ahead. I'm not going to give this answer. He was treated with several antibiotics. He approached us at 10 weeks and almost 12 antibiotics were tried. He was not responding and presented to us at 10 weeks with very high fever, high WBC count, and CRP going through the roof. You can see the operative scar, which was a very small scar. That was the repeat scan, which showed the disease process far more extensive than the previous image. And then obviously I explored. At exploration, you can see the small window and deep, thick pus inside. And naturally, I had learned my lesson and I wanted to make a big window. So here you can see the window being enlarged. That's the window that is enlarged. You can see deep inside there is pus. And this was the era before biodegradable local antibiotics. So I scraped, I packed the wound, came back at 4 days, and I had a very, very clean wound. So I just closed the wound with this clean cavity. I had made a good window, but I have not stabilized him. And he was treated with, again, appropriate antibiotics. I'm not going to say which antibiotics. He improved immediately. He was discharged. He was kept non-weight bearing for some time, for about 2 to 3 months. And you can see at 3 months, he has got a good bone formation at the edge. This is at 1 year. Excellent movements. And this is at 6 years. You can see the cavity is almost closed. So if you do a good job, a very thorough debridement, you really don't have to stabilize these, even if you make a good window. So here you can see at 3 weeks, at 6 years, the window is totally closed. Now, what do I conclude from this case? It is very important to address the disease process adequately. Nature would form bone. The moment you have taken out the pus, the body is in a hurry to prepare good bone and support the edges. We have to avoid stress rises around the edges. That's very, very important. So let's go ahead with the third case, because that would also answer several queries that are raised on the chat box. You have all gone through this case, a very extensive case. Again, osteomyelitis of the femur, which was diagnosed as osteomyelitis clinically by blood investigations and by MRI. You can see a cloaca that is allowing pus to come out, mainly on the medial side. And question was, what is the stage of this? Now, again, we have a divided house. Almost equal number have said that this is stage 3 or stage 4. And almost 21% have said that this could be either stage 1 or stage 2. Now, what is this classification? What is this host? Majority have said that this is B-type host. A few have said it is A-type or this is C-type. Now, I'll explain what is A and A, B, C. Almost everybody? Everybody has said that this is classification by Cierny-Mader, which is a very, very popular classification after they published this paper in 2003, a paper which is worth reading. Everybody has said, 100% have said that is Cierny-Mader's classification. So, do you treat him empirically? 50% have said that, 3/4 have said that will not start antibiotics empirically. But 1/4 have said that they will start antibiotics empirically. If no, would you do an image guided or you would explore? Majority have said that they would explore. In case you will not explore, what would be the antibiotics? Again, there is a varied response. 45% have said they will start with cephalosporin, while many have said they will start with piperacin, tazobactam. Nobody has said about meropenem, but linezolid or combination, so on and so forth. Now, this patient was started on amoxiclav by the index surgeon. He was not settling, so he consulted another surgeon. Now, my question was, what incision will you take? Lateral, medial, or swashbuckler? Here you can see red, that is almost 60% have said they'll take a medial incision. Almost 30% have said they'll take a swashbuckler approach because they'll be able to go on medial as well as lateral side. Where will you make the window? Lateral, medial, or you will just scrape through the cloaca? Again, almost 65% or 2/3 have said that they'll make a medial window. 16% have said that they'll go just scrape through the cloaca. And almost 20% or 1 in 5 have said that they will make a lateral window. What will be the size of window? Now this comes an interesting answer. About 40% have said that the window size will be equal to osteomyelitic cavity. But majority have said, that is 45%, that they will just widen the cloaca from all sides. And 16% have said that they will not make a window, they'll just scrape through the cloaca. Now, as regards the culture, how to collect culture, we had allowed multiple options. So 45% said they'll use a swab stick. 1/4 said that they'll use a sterile leak-proof container with normal saline. 50% said that they'll use a leak-proof container without any additive. 1/4 said that they'll use BACH or blood culture bottles. And 35% have said that they will also send a culture, send a tissue for histopathology. Now, the significance of all this we would be discussing at the end of this session. Now, I'll go through the case again. He was operated by the medial approach and he started the patient on appropriate antibiotics. Unfortunately, the patient was not settling, and that was the time when he approached us. So it was decision time as far as our group was concerned. We repeated the MRI. The process had progressed significantly. So again, coming back to the question, what will you do? Will you step up the antibiotics or you will explore? So the red is you will explore. So majority have said we will explore. Almost just about 1/8 have said that they will step up the antibiotics. When will you re-explore? It is always said that if a person is on antibiotics, the culture may not grow. So you'll have a negative culture. So should we wait for 2 weeks or should you go ahead with surgery immediately? Again, 1/3 have said that you will withhold antibiotics for 2 weeks. 2/3 have said that they'll go ahead and do surgery. Medial incision or extending medial incision or medial incision a little different way, or take a lateral approach and a bilateral approach. Again, majority have said that they'll take a medial incision in some form. 12% have said that they'll take a lateral approach now, while another 12% said that they'll take a bilateral approach. Now, what about window? The majority, 50%, have said that they'll extend the existing window, while some have said that they'll explore through the same window, while 1/5 have said that they'll make a separate lateral window. Now, I'll be explaining all these things and our line of thinking. Will you stabilize or no? Almost majority. Why almost majority? 5/6 have said that they will stabilize this because they will be making a big window. And what will be the implant of choice? Different types, but most of the people have said they'll use a nail. So our line of thinking. Patient was not settling. He was diabetic. He was toxic. And we have to explore. We cannot afford to withhold antibiotics for 2 weeks in a patient who is already toxic. He'll really go down. And then once he starts going down, you will not be able to salvage him. The aim would be to aggressively take out all the pus, biofilm, everything from inside. So I have to have a good access for clearing the infected tissue without unduly weakening the bone, as I showed in the second case. Now, my incision has to allow excellent access for a good window and all possible sites of infected tissue. Now, how do I judge the possible sites? And this is where we'll come back to the classification. The first thing that it explains, stage 1, 2, 3, 4, explains the anatomic involvement. Stage 1 is medullary. That means the cortex per se is not much involved. It is limited in the medullary cavity. Stage 2 is, so in short, for stage 1, remove the nail and dream. For stage 2, it is superficial. That means only part of the cortex is involved. There is still a cortex remaining between the involved cortex and the medulla. So one can just remove the layers of infected bone till viable bone is exposed. What is stage 3? Cortex and medullary medulla both are involved, but there is uninvolved bone present at the same axial level, and therefore axial stability is not compromised. So this fits in the stage 3 because we have some bone remaining at the same level as the defect or involved bone, and we do not have axial stability compromised. While stage 4 involves a segmental involvement of bone and it is actually unstable. So any infected non-union will be actually unstable because a segment of the bone is involved. So here we are dealing with stage 3, and therefore we need not stabilize this fracture. It's not fracture, stabilize this case of osteomyelitis. Coming to host type. Host A is normal. There are no comorbidities. B type host is, there is some compromises. Now B with small s is BS is systemic compromise. If there is a local compromise, then it is BL, small l, or B type host with small l. If there is local as well as systemic compromise, then it would be BSL. That means systemic compromise, local compromise. And C type host is treatment worse than disease. Now, this is obviously a very subjective thing. How does one decide whether the patient cannot be treated elsewhere? So essentially, it is a very, very subjective thing when you say a C type host. And these are the various conditions where it would be a systemic compromise, or it would be BS, or a local compromise like lymphedema, major vessel compromise, small vessel, vasculitis, venous stenosis, so on and so forth, where it is a B with local compromise. Now, in this case, what we decided was we need to get rid of the infection. So you must anticipate, like Sherlock Holmes, where would the infection be situated? In soft tissues, so that means previous incisions, previous drain sites, previous sinuses, or even adherent scars. All that has to come out. Bony areas, medullary canal, cloaca, and something which is often overlooked, and that is intracortical abscesses, which open superficially as well as deep. We will show you now here you can see there is no axial instability, but you can see the small areas that are involved, or intracortical abscesses, which are seen very, very well here in this CT scan. And you need to really plan how you're going to approach all these areas. Very often the recurrence is because of this. A, because of inadequate window, and B, because of these small cortical abscesses not opened. So in soft tissues, you need to identify where is the previous incision, where is the previous drain site, where is the previous sinuses, and are there any adherent scars. In this case, you can see there was a drain that was put in, and your incision should not just extend, but it should include the scar of the drain site. Now you must study the MRI carefully. You should also go and discuss with the MRI specialist, find out where is the abscess, where is the cortex, and most important, where would be your blood vessels. So with all that, you have delineated your intracortical abscesses. You can see there could be intracortical abscesses inside the medullary cavity. There would be intracortical abscesses opening into the outer side cloaca or under the thick periosteal reaction. And based on all that, you have to make a decision about your window. Go from areas where the cortex is already weak. It is already weak, so just include that in your window. So from all that, your cortex is weakest on the medial side. Your soft tissues are maximum on your weakest side, on the medial side. Your intracortical abscesses are most on the medial and partly on the anterior side. So it is best to extend the medial defect, get good access. On the other hand, if you make a lateral window, you will cause axial instability in him, and also you will not be able to approach all these areas properly. Now, we need to make a medial window, that is for sure. Obviously, we all were scared. Me and Aditya were so scared about making a medial window because we would be endangering the femoral vessels, and we were worried that going through this adherent or infected area, we might endanger the femoral vessels when we make a large window. So we discussed with our MRI consultants, who said, don't worry, your scar is away and your femoral vessels are away. You can see the scar here and the femoral vessels. So he said, if you stick your knife and everything on this side, you should not have a problem. So this is where we are. That's the inclusion of drain site. This is where, as we opened, we could see a thick walled abscess because of several antibiotics over several weeks. And then this was the cloaca and a window. Cloaca and window were adjoining. And then we started extending the window, and you can see we have made a big window with reasonably rounded and smooth margins. And we could access the granulation tissue very, very well. And this is where one often makes a mistake. This area, unless you open the periosteum, you will miss this intracortical abscess. Again and again, I'll keep saying that this is very likely to be missed. Be very, very careful about that. And now this is our window. You can see underneath is the gel foam, and we closed over the gel foam. Came back, put in vancomycin, CSO4 or stimulant after 4 days. And this is him at 8 weeks, very, very comfortable. You can see he has excellent range of knee movement also. This is at 3 months. You can see the chart where ESR, CRP are decreasing. We ask patient to keep this chart, including blood reports, his clinical parameters, the appetite, the pain, fever, everything is WhatsApp to our resident every week. So we can keep a very close watch on their clinical condition. This is at 3 months, X-ray without a problem. And this is at 9 months. He is not prepared to go for X-ray because of Corona. He said, I am diabetic. I just don't want to go for an X-ray, but he is very, very comfortable doing almost everything. So there is really no need, even if you make a good window, to stabilize these fractures, these conditions with the this thing that it may fracture. If you make an adequate window with keeping these principles in mind, make it with make a smooth window, edges should be rounded off. Good old days, we used to make a rectangular window, and that is the most troublesome thing. Never make a rectangular window. Window should be elliptical, smooth margins, include cloaca so that you get rid of the weak cortex, and then you should not have a problem. So this case has taught us the planning of incision, planning the window, and most important, analyzing CT and MRI from a surgical point of view. If are there any questions on chat box, I think I'll take them. Aditya, are there any questions on chat box?
Yeah, there are a couple of questions.
Yes.
So just read it out. Dr. Kiran Makwana has asked tips on how to determine on-table completeness of debridement or the endpoint of debridement.
Subjective. Once you feel you have done a good debridement, give a wash, pack, sit for about 5 minutes, chit chat, and come back and check again. Check again. See the MRI, confirm that you have gone through everything. Several times we have picked up these intracortical lesions or small areas. In fact, many of our residents have become expert in this, and very often they say, sir, you have not done this. And I'm really honored to say that in 2 cases when I thought that I've done a complete debridement, my grand juniors picked up and said, sir, I think you have not done this. I mean, yes, you can say that I am not a good surgeon, but listen to your juniors also, a totally third person. But as I said, sit for some time. Don't start closing. Give wash, pack the wound, wait for some time, come back and check.
If I could add a point there, I think in all of that, the preoperative planning with the radiologist helps a lot to determine exactly where the cortices are, the cloaca are with respect to joint line or some anatomical landmarks. So that adds to your planning and decision making. There are a couple of more questions by Dr. Srinivas Reddy on power saw or osteotome. What do we use to make a window? And Dr. Rahul Pawar has also asked the same. What instrument do you use to make a rounded window or an elliptical window?
You like to take that?
Yeah. So most of the times what we do is use a 2.5 drill bit and mark the elliptical window with a cautery. So we know what is the exact site we go. And then we start making drill holes along that mark. Important point is start making the drill holes along the 2 ends of the window first, so you don't accidentally extend. And once you've made multiple drill holes along the oval or elliptical mark, then take thin osteotomes. Start with a 5 mm osteotome and start at the edge. So the first hammer would be between the apex holes on one side and the just hole adjoining it. So the idea is to make a curve right at the beginning so that your osteotome, when it extends, does not break into the normal bone. So you make 2 curves on one end, make 2 curves on the other end, and then bridge the cortices between. And the first hammer should be just to make a dent in the bone and not to go completely. So that dent makes a weak area for you to go along. And once you've made the dent along the entire window, and then go ahead and complete the window.
Now
we've also used power. Yeah, sorry, sir.
And after that, the window generally becomes very irregular. And that is the time when you should use, we do have a Midas button. You can use any burr, ENT burr or any burr to round off. Otherwise, use nibbler to round off. But the window has to be rounded. Elliptical window with rounded ends. You can use a duckbill nibbler at the end if you are strong. I am lucky that Dr. Aditya is there and a really strong man. So he can chip off the end of the window with a duckbill nibbler. It becomes really round. Any other question?
No, I think those are the questions on the chat box.
Okay. So we go ahead. This is a young boy has multiple discharging sinuses for more than 2 years. He was operated but had not settled. This was absolutely adherent. The MRI was suggestive of infection, and the MRI showed that the infective process was in metadiaphysis, which was going through the fascial plate into the epiphysis. So that is what I had asked. Most of the times, friends, it is MTB. MTB often passes from the metaphysis and can perforate through the fascial plate. It doesn't mean that others don't, but you must always keep MTB in mind. So another case to show you, MTB perforating through the physis. So we did an aggressive debridement, excised, did a local flap, and this is how he is. He turned out to be TB, appropriately treated, and the result is absolutely good. Now, Dr. Aditya, can you share with them your slides? Because friends, this is a very unique classification that has been proposed and published in 2019, what is called a BACH classification, which takes into account skin, soft tissue, and antibiotic resistance. So over to Dr. Aditya.
Yes, sir. Yeah, like sir said, this was a new classification which has come up in 2019. So this group of surgeons and ID specialists, what they've done is reviewed literature on various classification systems, tried to find the lacunae in each, and then combine a classification which includes various variables, not just surgical but medical as well, and try to improve the inter-observer reliability. So a lot of people could then use this classification and come up with the same classification for a particular patient. So the 4 variables, so BACH is actually a class, is an acronym and not the name of a surgeon. So B stands for bone involvement. So that's your B variable. So these 4 are variables. The first being bone, second being antimicrobial or antibiotic options. That's A. C stands for coverage by soft tissue. That's your plastic surgery cover. And H, so BACH. H stands for the host or the patient status. That's your H variable. So these are the 4 variables. The names itself explains it, BACH. Now going into each one, your B variable or your bone involvement, B1 is a cavitary infection without any joint involvement. The cavitary could be cortical, it could be medullary, or it could be cortico-medullary but not involving a segment. So if you extrapolate it to a Cierny-Mader classification, your first 3 types would be your B1, whereas B2 is a segmental infection without any joint involvement. So that would be your type 4 in your Cierny-Mader, where an infected non-union would be classified as a B2. The additional thing that this classification has added is a joint involvement. Now, if a joint is involved, then whether it is cavitary or segmental is both come into B3 as long as the joint is involved. So that is a new thing that they have added, because a lot of times we see metaphyseal osteomyelitis in a distal femur breaking into the knee. So that becomes your B3. Looking into the A variable or your antimicrobial variable. Now, antimicrobials or resistance pattern is something which is very difficult for orthopedic surgeons to understand. So they've simplified this and said A1 would be a negative culture. A1 would also include a bacteria which is sensitive to more than 80% on an antibiotic. So you look at your culture sheet, your antimicrobial resistance sheet that we have. If it's resistant to 80% of the antibiotics, sensitive to more than 80%, or resistant to less than 3, it would be A1. That means most antibiotic options are available. A2 would be which is sensitive to less than 80% or resistant to 4 or more. The another thing that they've added and very important point here is, especially in implant-related infection, is a antibiotic which has activity against biofilms. So for Staphylococcus, it is rifampicin, and for gram-negative infections, it would be fluoroquinolones like ciprofloxacin. If there is resistance to one of these, so for Staphylococcus, you look for rifampicin, and for gram-negative, look for ciprofloxacin. If that's resistant, then it becomes A2. That means you don't have an anti-biofilm acting antibiotic in your armamentarium. And A3 would be any bacteria which is sensitive to only one or resistant to all. So that means it's a highly resistant organism that becomes A3. So that is the hierarchy that they have given. Rather than going into MDR, XDR, all those definitions become difficult for surgeons to understand. Then coming to the C variable, that is your coverage. It's very simple. C1 means direct closure is possible. You do not need a plastic surgery. And C2 is you need plastic surgery, whether it's a skin graft or a flap. Looking at the host, host 1 is well controlled, either a fit patient who does not have comorbidities, that would be your A host in Cierny-Mader, or patient who has a comorbidity but is well controlled, a well controlled diabetic would be your H1. H2 becomes a poorly controlled comorbidity, like a poorly controlled diabetic, sugars are not in control, or a severe comorbidity which causes end organ damage, like a chronic kidney disease or end stage liver failure. Those would become severe comorbidities, or a heart failure. The other thing that they've added in H2 is a recurrent osteomyelitis. The patient who's had previous debridement, but the infection has recurred. That becomes a local failure, so that is why it comes in H2. And this is H3 becomes in patient who's unfit for surgery or a patient who declines surgery. So that's an error there. That's H3. Somebody who's unfit or a patient who declines automatically becomes H3. Now, each of these 4 variables has 3 bands. A green band, an amber band, and red. The red band is present in only 2 of the 4 variables. A green band basically means it's uncomplicated. An amber band or an orange band means it's a complex surgery, or a red band obviously means there are limited options or no options. Now, when we look at each of these criteria, B1, that means cavity would be uncomplicated. It's logical. A complex would be B2 or B3 with a segmental involvement or a joint involvement. When you look at antimicrobial, sensitive ones would be A1, less than 80% sensitivity would be A2, whereas the highly drug resistant, where only one or no antibiotics, is A3. That's again follows this hierarchy. C1 and C2 would be green, and no plastic surgery or plastic surgery would be uncomplicated and complicated. And a patient who's unfit for surgery automatically goes into the red band. Now, what they have said is, you look at all 4 variables, and even if the patient is categorized based on the most severe variable. So if a patient is A3, even though he may be an uncomplicated B1, but if the microbe is resistant, automatically it becomes a red band patient. If the patient has sensitive bacteria, but he's unfit for surgery, like an H3, again, he becomes a limited option or a red band patient. So what they've tried to do is, if a patient is uncomplicated, comes in the green band, they say that is what the group has suggested, that it can be managed at various centers. Whereas if the patient is complex or limited options, it should be done in centers where a multidisciplinary team is available. So a plastic surgeon, an ID physician, all those options, or an ICU backup should be available. What they have done is taken this classification and assessed the clinical outcomes of these patients based on this classification. Over 71 patients, they've assessed the quality of life at various stages across a year. What they have realized is an uncomplicated patient obviously will have a better quality of life compared to complex B2 cases at all points in the year. Similarly, a patient with good antimicrobial options like an A1 will have better options than an A2. But whether or not a plastic surgery was needed does not determine the quality of life. Quality of life was equally good for C1 or C2. And the 4th variable, a patient without a major comorbidity, like an H1, would report a higher quality of life. So what they said is uncomplicated cases have better quality of life. Complicated cases, when asked that how many feel that they are back to normal, only 1 on 4 said they feel that they're back to full health status. So these complicated cases, they say, must be referred or managed at a center with multidisciplinary team. And in spite of everything, they do not feel that they are back to full health status. Almost 75% do not feel that. So this is a classification. It's pretty comprehensive. It's covered a lot of aspects, clinical and microbiological with surgery. So that is how it's added value to the older Cierny-Mader classification.
Yeah. Thank you, Aditya. We'll go ahead.
There was one question by Dr. Srinivas Reddy on culture. So that I think we'll cover when I cover the talk on cultures.
Yes. Dr. Aditya will be discussing about cultures. So I go to the fifth case. An elderly gentleman, history of lymphoma, had received chemotherapy a year ago, had UTI 6 months ago, and then presented with pain and swelling in the shin. So obviously UTI and his bone got infected. You can see there is a periosteal reaction on the anterior aspect, and the MRI is absolutely classic. You can see there is a good cortex there, and the lesion is absolutely superficial. There is a part of cortex which is preventing that lesion entering into the medulla. So the medulla is not involved, it is only the cortex that is involved, and therefore it fits into stage 2. So almost 40% have said it is stage 2, but about 30% have said that this is stage 3. Some have said it is stage 1, some have said it is stage 4. So again, you can see it is a good cortex here, which is preventing that infective lesion going into the medulla. So it is superficial. What is the host type? He had lymphoma. So obviously he goes into type B host, that is compromised host. So that's a superficial and compromised host. So how does one plan? You have to keep removing the cortex till you have a good cortex. See, very often we try to do an en bloc resection. Most of the infected areas we try to do en bloc resection. Here one has to be very careful, because if you try to do an en bloc resection, you might actually go through the intact cortex and the infection would go to the medulla. And therefore, it is better to open the lid, scrape and excise the wall. As you can see, open the lid here. You can see, just open the lid. You can see the osteotome here. Open the lid and you can see the infective tissue there, which is removed, and till you reach the normal cortical bone. He grew Klebsiella, and we will discuss about gram negative a bit later. This is him at about 5 months, I think. Absolutely comfortable. Now, the last case that I would be discussing today is again shared with you. A middle-aged lady with multiple episodes of discharging sinuses for several years. She was on antibiotics off and on, even ATT was taken. Now, the real concern here is how do we take an incision and possibility of radial nerve injury. Because she had a huge sequestrum almost in the middle half of humerus. So best way is to mark the radial nerve, and obviously everybody almost has said that they would include the sinuses. Absolutely. You need to include the sinuses, which will take you to the cloaca, and that's the incision mark. The first step is keep feeling for radial and isolate the radial. So the radial was isolated. Here you can see the sinus and sinus tract going into the cloaca. That's the radial nerve, which had to be traced way below. That is another part or another cloaca with skin there. So this is the entire skin that was separated, which was anchored by cloaca to the bone. This is the sinus tract going into cloaca. And now you can see the 3 cloaca that were opened, that were identified and window made. And this sequestrum was removed, which gave good access to scraping the humerus. And that's the various different containers. Dr. Aditya will explain to you. We put vancomycin stimulant inside at a second sitting when the culture report was available. And that's her at 1 year, very, very comfortable. So, Dr. Aditya, I'll share the screen and you can answer about the culture. How do we,
Yes.
how to take cultures, what samples to take, so on and so forth.
So the question was, I think, I'll just go through the question. Whether when do we take the sample, whether before or after the wash? So I'll explain that through this talk. So the idea for any debridement for all of us is to try and identify the bacteria, because without which we're all shooting in the dark, giving empirical antibiotics. Even the physicians are find it difficult to know what antibiotics to give, especially in the setting of increasing drug resistance. So the idea is to maximize the culture yield and to reduce that no growth phenomena that we keep seeing. Now, how do we do that? There are various things that we can follow. They're very simple things. One is preoperative, where we can look for an antibiotic-free period, communicate with the ID specialist, send appropriate sample, keep appropriate sample media ready. Next is postoperative intraoperative strategy, where we decide what to take, when to take, and which tests to ask for. So a preoperative strategy, the first and most important thing is the antibiotic-free period. Now, whenever all of us see patients in our clinic, most of them have come after taking multiple courses of antibiotics. If it's a chronic osteomyelitis or something which has been going on for a long time, most of these patients are clinically stable. So we must try and get a minimum antibiotic-free period of 15 days. And I understand it's very difficult to explain that to the patient, because they keep saying that antibiotic nahi hoga, so then if there are no antibiotics, then the infection will increase. Yes, there is a chance of infection, of the infection to suddenly come up if the antibiotic is stopped. So if there is fever or severe pain at the time of presentation or after stopping antibiotic, or there is a sign of septicemia like a raised WBC count, or there is significant purulent discharge or an impending abscess, or a diagnosis like a necrotizing fasciitis. In all of these scenarios, we cannot wait, or we should not wait. We are bound by these clinical findings, and we have to go ahead and debride even though the patient is on antibiotic. If none of these are there, and none of these happen in the next 15 days when the patient is off antibiotics, then we must operate only after an antibiotic-free period, because that gives us the maximum chance of improving our culture yield. Now, we've learned this from Dr. Soman. He is a very senior ID physician who was at Hinduja, and he's actually discharged our patients who were admitted for an osteomyelitis, was on antibiotics. He assessed the patient, said, no, this patient is clinically stable, send him back home. We've admitted the patient after 15 days again, having discharged the patient once he's admitted for surgery, explained it, admitted again, and we got a culture. So it's easier to do it once you've explained it to the patient in the OPD and plan a surgery after 2 weeks, provided none of the symptoms that I've explained or the raised counts are present. Second, and very, very important, is avoid a swab stick in the OPD or in the surgery. One simple reason is there are multiple studies which show that the swab stick just gets your superficial bacteria or a commensal from the skin, which is a contaminant and not the actual pathogen. So when you take a swab, they've taken a swab, and in the same patient, they've taken a deep sample during surgery and found only 1 in 5 samples match. So you'll get something from a swab, but it will not be a representative bacteria, and the infection will come back. So you've taken a swab, spent money on a culture, given antibiotics, and the infection comes back. So the chance of getting a positive culture later on also reduces, and you've lost some time. So a superficial swab really does not help in diagnosis. And once we are in surgery, we still have the tendency of taking a swab stick. Now, once we are in surgery, we have the option of sending everything that we see. So why use a swab stick which has a minimal sample? Third is, the next point is communication with the ID specialist or a physician or a microbiologist, depending on whoever is available wherever you practice. The reason is they take a detailed history. They find clues even in the travel. There are certain areas where patients are prone to certain specific infections, bacteria. Things like seawater exposure have given, they've told us that patients had a seawater exposure infection after that. It could be Vibrio, and that is what we found. IV drug abuse is related to certain bacteria. These are things that we generally don't look for. We miss out. Second is they help us by telling us what tests to send, whether we should send for bacteria, TB, fungi, based on the history, or all of them. Third is, and this is something that we should also remember, that if a patient has had a previous surgery, especially an arthroscopy or an implant or an injection within the joint after which, or like a steroid injection, these patients tend to have something called as a non-tuberculous mycobacteria, and or a shoulder surgery has propionobacterium, which is called QT bacterium acnes now. Now these bacteria grow very slowly. They don't grow in 5 days. They take about 10, 15, 20 days, sometimes longer to grow. The dictum in any micro lab is if the culture does not grow over 5 days, the sample is discarded. But if you've communicated with the microbiologist or your physician has communicated with the microbiologist that we may suspect these bacteria, please keep it for an extended incubation. The sample is not discarded. It's kept for a longer time. And most important is that the patient is on antibiotics at the time of surgery, has been on antibiotics within the last 15 days. Even then, your standard bacteria also sometimes take time to grow. So in all these scenarios, we must explain and convey to the microbiologist that please keep it for an extended incubation and look for these specific bacteria. Third is, once we've planned and we've decided or communicated that we need to send XYZ sample, we must have the following things ready in the surgery, in the operation theater. One of the commonest things is a BACTIC bottle, which is readily available in most micro labs across the country and across the world. It's you can procure it from the lab and they can send it across to your hospital. Now these bottles are sealed. They take in any fluid. It could be blood, it could be synovial fluid, or it could be pus. There are two kinds. One is an aerobic bottle for aerobic culture. Second is anaerobic bottle for anaerobic culture. Now, anaerobic is generally for foul-smelling infections where you expect anaerobic, like Streptococci. But by and large, what we do is if we have a fluid, we divide it into two, put 2 to 3 ml in aerobic or 2 to 3 in anaerobic, or whatever you have divided into two and inoculate it in both the bottles. Again, each of these, whether aerobic or anaerobic, has two kinds, standard and BACTIC plus. Standard is a standard bottle. What BACTIC plus has is resins. Now, these resins help us by inhibiting antibiotics. Now, if your patient has been on antibiotics in the last 15 days or even sometimes earlier than that, you can use the BACTIC plus bottle, BACTIC plus aerobic, BACTIC plus anaerobic, and put your fluid into that. So the resins will inhibit the antibiotic and chance of getting a positive culture is higher. The other and very important advantage of these BACTIC bottles is it's actually a culture medium in the bottle. So the minute you inoculate it during your surgery, the bacteria have already started growing in the culture medium. So you get an earlier sensitivity within 48 to 72 hours, you have the culture report versus 5 to 6 days sometimes. The second one is your sterile leak-proof containers. These containers are easily available. They may be in your hospital again or in a microbiology lab. You can put in all the fluids that you put in your BACTIC bottle. Also, they are used for tissue. Now, the tissue can be sent for both culture and histopathology. So the practice we do is label these containers, 1 sample 1, sample 2, sample 3, depending on the area where you've taken it. Write it down on a glove paper or any sterile paper with a marker. So you don't get confused at the end of the surgery as to what has come from where. So these were the preoperative strategies. What about the intraoperative strategy? What do we take? How much do we take? What do we ask for? Now, the first step is, what do we take? Most of the patients may have a sinus. Try and avoid taking sample from the sinus because there's a lot of contaminant. But we must send the sinus tract for histopathology. In very, very rare cases, we've seen sinus tract showing evidence of squamous cell carcinoma, especially long-standing sinus tract happening for years, 5, 10, 15 years. That's very uncommon, but as a norm, we send it for histopathology in every case. The first sample that we should generally take is from above the implant, or if the implant is not there, then from the surface of the bone or deep to the implant. So that becomes your sample 1, this becomes your sample 2. You can see in this case a biofilm, dirty biofilm on the bone. That entire thing is removed en masse with an osteotome and put in a container 2, labeled container 2, tissue above bone or tissue under implant, depending on where you've taken it. Your third sample this is just arbitrary. You may have multiple samples if you're doing a joint infection from the tibia, from the femur. The third sample in this case would be at the non-union site if it's an infected non-union, or the medullary sample. If you've done a medullary scraping or reaming, that would be your third or fourth sample. So that way you have multiple samples from multiple locations, above the implant, under the implant, from the non-union site, from the medullary canal. So you can have 4 or 5 or 6 different samples, label them separately. What do we put in what? Like I said, fluid goes in your bacterial bottles, whether it's pus, blood, or synovial tissue or synovial fluid. Now, one issue that we face with chronic osteomyelitis is it's all thick, inspissated pus. It's not liquid pus like in an abscess. So we find it very difficult to take it in a syringe. So what we have started doing at Induja is whenever there's a deep hematoma around that infected area, not the superficial blood within the subcutaneous tissue. This is once you've reached the infected site, the blood around that we aspirate and we put it in the bottle, and we've inoculated bacteria even from this blood. What you can also do is take a little bit of 1 or 2 cc saline, mix it in that area where it is dirty and marked, and put that fluid in. So you are inoculating something from the actual infected area within your bacterial bottles. Second is your tissue or your granulation or medullary scraping goes in your sterile leak-proof containers, one for culture, one for histopathology. A lot of times, your culture may be negative, but your histopathology may give you sign either inflammation, which is suggestive of infection, or in atypical mycobacteria or your standard TB, you will get a histopathology which shows granulomas. So your culture may be negative, but your histopathology there has helped you prove that this was a tuberculosis, whether atypical or typical. Third is when you're doing a synovial fluid aspiration, whether it is from a native joint or after opening or after a periprosthetic joint infection, we must send 2 to 3 cc of the synovial fluid within an EDTA bulb. That gives us the synovial fluid analysis. That means your neutrophil count, your total WBC count from the synovial fluid, the protein, glucose level, all that gives you an idea of what is the state of the synovial fluid, gives us an idea of the state of infection. Then comes your dilution. It's established that for histopathology, formalin has to be put in. As far as culture is concerned, if you're operating at a time of the day where you know that your sample will reach the microbiology lab within that day or within a few hours, do not add anything to your sample, not even saline, because the sample is moist enough, it will be fresh enough, and it will be processed in the micro lab the same day. But if you know that there is going to be a delay, or you've operated in the evening, or the micro lab is not in your vicinity, it will take time for the relatives to go with the sample. It's going to be processed the next day. So what happens is that sample dries up. Then the culture yield becomes lesser. So we need to add a few drops of saline just to keep it moist and viable. Do not put 10 cc of saline in which bits of tissue are floating. No, that doesn't help because that dilutes all your bacteria. So just put enough. I mean, it's very subjective, but enough to keep it moist till the time you know that the sample is reaching your lab. Now, most important question, what do we send for? There are multiple things mentioned on this slide. As a protocol, we send all of this for every patient. Smear helps us with the gram staining or AFP staining. A lot of times the culture may be negative, but your gram stain, which is a very simple process, comes out within a few hours, will tell you whether it's gram positive foci or gram negative bacilli. Fungi can also be identified on smears. That helps your physician decide what antifungal or antibiotic to start on, because the treatment for each gram positive, negative are different. Second is your standard aerobic anaerobic culture, which helps you with your antibiotic sensitivity. Now, fungal cultures may or may not be available, but it's preferable that you send it, especially in patients who are immunocompromised or open injuries. Like I said, as a protocol, we send it for all our patients, whether they are immunocompromised or not, whether there's an open injury or not. Even in a closed fracture which has got infected, we've sent it. Surprisingly, we found about 15 to 20 fungal infections in cases where we had not even suspected it. And we would have failed in treating that patient had we not found these fungi, because the treatment is completely different. Fourth is your gene expert. Now, gene expert is typically used for tuberculosis, but it also has some role in non-tuberculous mycobacteria, which we'll explain in further sessions as to how a gene expert and MGIT culture help us diagnose whether it is typical or atypical TB. The other thing is we don't know what bacteria we're dealing with. So if you don't send it for gene expert, you'll never know whether it is TB or not. Similarly, your TB MGIT culture, which is for your find out the presence of mycobacterium and the drug sensitivity. You may think it is bacterial, and we have also assumed the patient to have a staphylococcus infection. It turned out to be tuberculosis. Similarly, we thought of a patient being tuberculosis based on history. And because we sent it for an aerobic culture, we found that it was staphylococcus. It was a low-grade staphylococcus infection, and we had clinically never suspected it. And the last and the most important is histopathology. Histopathology will help you as far as mycobacteria is concerned, as far as fungi are concerned, and even something as simple as an acute inflammation on histopathology proves that this is an infection, because infection is an inflammation with a bacteria. Histopathology will not give you the bacteria, but they'll tell you that there was inflammation. So we send all of this for culture, for analysis. Now, the problem is when you send all of this, the cost of each sample could vary from 2,000 to 10,000 rupees. Now, 10,000 rupees for one sample is very, very difficult to explain to the patient. And if you're sending 4 samples, that would be anywhere between 10,000 to 40,000 rupees, depending on where you're practicing and the cost of the microbiology test. Now, that's something which is practically difficult to do. Literature says we should send 4 to 5 samples in every patient. What we can do and modify as per our local settings is take the cultures in the appropriate bottles that we've labeled, put it in the BACTEC bottle, put it in various containers. Then at the end of the surgery, take appropriate samples and maybe club them into 2. But ask for all the tests, because as surgeons or as physicians, we should not try and guess. Yes, we must know what it could be, but just because we think it is XYZ does not mean it is going to be XYZ. So we can reduce the number of samples, but try and send it for everything, because we may find a tuberculosis where we suspected bacteria and vice versa, or even fungi. So this is how we can try and maximize the culture yield and minimize the no growth. As far as the question about taking it before wash or after wash is, we must always take the samples first, then give a wash. If after your debridement, after your wash, you feel that there was still some tissue which you feel you had missed out, you can still send it for a culture. The most important thing is avoid giving an antibiotic. The prophylactic antibiotic that we give for clean surgeries should not be given in infected cases or suspected infections. After you've taken your sample, after you've taken everything that you wanted, then you can ask the anesthetist to give whatever antibiotic you have planned to give the patient. And if the tourniquet is inflated, give the antibiotic about 10 minutes before you deflate the tourniquet, because the antibiotic otherwise will not act. So that is how we've come to out with a strategy and a protocol, and we've had almost 75 to 80% culture yield in most of our cases following these simple protocols.
Thank you, Aditya.
Yes, sir.
Thank you. I think you have answered most of the questions, but I'm sure there would be some. So do share on your chat box in case you have any queries. I don't see any in the chat box. Is it? No. Otherwise, I'll go ahead.
There's one question by Dr. Rahul. Is it advisable to use cautery to clean the biofilm after scraping?
I don't think so, because you would be causing more necrosis. Basically, it has to be by mechanical means. What is your opinion?
Yes, sir. We generally use scoops to scrape out the medullary canal. So that is enough, because cautery to remove the biofilm within the canal would be practically impossible. Even on the surface, use a surgical knife and an osteotome to clear out the biofilm.
So, friends, what did we learn today? I think the most important message we would like to give is avoid this. Avoid fracture through windows. And there have been several different ways of making a window. Now, this patient came to us with a fracture because there were 2 windows made to scrape the osteomyelitis. Now, this obviously made things very, very weak, and he had a fracture. Another friend of mine, just recently, 6 months ago, he sent me this X-ray and asked me, why did this fracture occur? So this was the young patient who was operated about 2 weeks ago. You can see the staples also, and you can see the window made, and some unusual things you would notice is you can see this piece, which is obviously here. this piece. So naturally, what has happened is the window that he has been made, that cortex has been put back. So I've traced the X-rays. This was an MRI, which is almost similar to whatever cases we had shown. MRI was suggestive of infective process. The surgeon, that's the MRI report. Now, this is what the surgeon did. This is the window that was made. This is the window that was made. Scraping was done. He put in antibiotic with stimulant, and he put back the window. You can see an absolutely rectangular window, and these points made that into a stress riser, and that's the this thing, and that is why he fractured. So the disease was not cleaned appropriately, and there was a definite stress riser with the window. So making a window is very, very important, and unfortunately, there have been hardly any guidelines as to how to make a window. And please see to it that your window is appropriate to take out everything, take out all the infected material. So finally, this is our first module, and we would like to explain the general plan of management of any infected or case of suspected infection. So we call it what is called a six-legged table. You need to have a multidisciplinary or multi-speciality approach. You need to develop a theme plan, but you are the ringmaster. You need to realize that you must behave like Sherlock Holmes. You must plan like an architect, and you must attack like a field marshal. So that's the six-legged table. So first and foremost, diagnosis. Appropriate diagnosis, whether it is infection or not infection. You are suspecting osteomyelitis, you are not suspecting osteomyelitis. And this is where the good old paper published in 75 helps us, whether it is a definite osteomyelitis, probable, or likely osteomyelitis. You must always establish the microbiological and histopathological diagnosis. So only clinical diagnosis is not adequate. Once you have diagnosed, whenever needed, radical debridement is indicated. We'll discuss in further modules when radical debridement need not be done. There's some cases where only antibiotics would help. First, another very, very important aspect is something that was discussed in the BACH classification, and that's cover. Always think whether you will be able to get a good cover or not. If you are not likely to get a good cover, involve a plastic surgeon. If you do not have plastic surgery nearby, either refer him somewhere or try and get plastic surgeon around, or maybe apply VAC after surgery and then transfer him for plastic surgery care. But you must plan and inform the patient and relative that a cover plastic surgery care may be needed. In appropriate cases, support or fixation is needed, either external or internal. We had some discussion about internal or external fixation. When is it needed? If there is an actual instability. Otherwise, more often than not, fixation is not needed. The antibiotics should be targeted antibiotics. Empirical antibiotics generally are not advocated. Local measures have come recently, like negative pressure wound therapy, which has been extremely useful for optimizing the wound, and also the recent developments of VAC Ultra as well as VAC Instill and that special foam with holes has been extremely useful in infected cases where very aggressive debridement may not be useful. Also, local antibiotics are useful. We will have a full session on local antibiotics. Something very important is the tabletop. The tabletop means right compromise at the right time. That means when to do debridement and when to do amputation is something very important. Very often, one tends to do all that a little late. When patient has started crashing, then there is no point in doing amputation because by then you have lost the war. So appropriate antibiotics at the appropriate time, appropriate compromise at the appropriate time. And lastly, dead weight on table. Dead weight on table is comorbidities. Diabetes, smoking, alcohol, malnutrition. If you don't address that and they are too big, they will go through your perfect defense and you may have a very poor outcome. Therefore, addressing these comorbidities and early compromise, especially in patients with comorbidities, is very, very important. Lastly, a word about antibiotics. This is something we will be discussing in future next sessions, but it is important to know that there are 5 different class of antibiotics. First is before microbes enter the body. When you give antibiotics, classically prophylactic antibiotic, which is generally given for a short period of time, 3 turns or maximum 1 day, 24 hours is something that is more than useful for a patient with closed fracture when you are using it for closed surgeries. Whenever there is an open fracture, the microbes have already entered the body. Though it is called prophylactic antibiotics for open fractures, it's a misnomer. Most experts believe that they should be called preemptive antibiotics. That means microbes have entered, you anticipate that these would be the microbes, and then you will give antibiotics appropriately. They are generally continued at least 24 hours after achieving a closure. Till then, you continue the antibiotics. Then in case patient develops infection and one has collected sample for culture sensitivity studies, then you obviously need to start antibiotics, and they are empirical antibiotics to be continued for a very short time till the culture is available, and that is when one starts targeted antibiotics or antibiotics based on the culture report, and they are generally given for 6 to 8 weeks. In soft tissue conditions, maybe 3 weeks, but whenever bone is involved, 6 to 8 weeks. Now, there are conditions where you have diagnosed infection, you have explored, but it is not possible to take out a metallic implant like a joint or a plate because the fracture is not united yet. Then one needs to continue antibiotics for a long time, and therefore they are called suppressive antibiotics and have to be taken for a long time. So these, you must know why you are using an antibiotic, and then you will be able to decide how long to continue and what antibiotic to continue. So friends, I'm sure there are some chat questions. We will answer them. And in case somebody wants to ask questions, Dr. Neeraj, can they unmute and ask? I stop sharing.
There are a couple of questions on the chat box. After we answer that, I think people can, the delegates can unmute.
Okay.
First is a couple of questions on investigations. Dr. Aveen has asked, should we always get a contrast MRI or only in doubtful cases?
Yeah, you can take that question, Aditya.
So what we generally do is, we suggest, what we write is SOS contrast. So the radiologist generally, if they find that there's evidence of infection or a tumor otherwise, they always put in a contrast, provided the creatinine is normal and the patient does not have a kidney issue. So by and large, for almost every case, we ask for a contrast enhanced MRI or a contrast enhanced CT scan as well, depending on the pathology involved. So the second question is the role of a cyanogram. If we are doing an MRI, is there any role of a cyanosogram?
Cyanosogram was extremely useful till the MRI came in, because with MRI you get most of the things, but still there are certain cases where there could be a foreign body, and very often MRI may not pick it up. A common would be when in an open fracture there is a discharging sinus and it continues for some time, then it is worthwhile doing a cyanosogram which will lead you to that foreign body. So in that case, in such a case, cyanosogram would be useful. But otherwise, good old days, we used to regularly do a cyanosogram. Today, we don't do it that often. But yes, it does have a place. In addition to that, there is something called methylene blue injection. I'm sure you all have heard of methylene blue. So if there is a sinus, you can inject methylene blue on the previous day. Don't inject it on the same day. It colors all the tissues, but only the sinus, methylene blue along the sinus would remain the next day. All the other areas, methylene blue will be absorbed in the body. So it definitely helps you to trace the path of that sinus and go to the source.
And one last question, sir. Pretty interesting question from Dr. Shashank. So what he says or asks is, we generally try and reduce or optimize our operative time in clean cases to reduce infection, because it's known that the prolonged surgeries increase the chance of infection. Does the same principle apply to operating an osteomyelitis case? Should you finish it quickly to prevent any recurrence?
I feel it is exactly opposite. You must take as much time, be as much careful as possible, come back again and again in that same surgery to confirm that you have gotten rid of the infection. So in this case, it is not vitally important. Our theaters are now almost everywhere the theaters are good. So he is not likely to get infected because you have kept it open for a long time. In fact, if you miss something, you will have a problem. So see to it that you do a thorough job, more than thorough job, and absolute thorough job.
I think we have answered all the questions on the chat box, sir. If there is anyone who would want to ask anything specific, maybe.
Yes, I think people can unmute one by one, and we have 5 minutes left. So people can unmute and ask questions. You can open your videos also. So let us, this being the first day, let us see all of you. Friends, please open the videos, unmute yourself, and please do ask questions. Or if any suggestions are there, please go ahead. Please feel free to tell us. Please feel free to tell us. Next, subsequent modules, whether you would like any changes. The plan that we have is next week would be open fractures for 1.5 hours, and 30 minutes would be discussion on pediatric osteomyelitis or septic arthritis. The third would be part 1 of infection after osteosynthesis of closed fractures, third and fourth. Fifth will be infections, soft tissue infections, pyomyositis and necrotizing fasciitis. Sixth would be tuberculosis. Seventh would be soft tissue cover, and eighth would be antibiotics. We have kept antibiotics last purposely because we'll keep on discussing antibiotics over next 7 weeks. And then at the end, Dr. Aisha, our infectious disease specialist, can compile everything and answer all the questions. Now, please go ahead. And
so Dr. Robert, good evening, Dr. Robert. He has a query for us.
Yeah, good evening. Thank you very much for the good presentation. I've really learned a lot from it. And I think right from the first day, I'm seeing a change in my knowledge about osteoarticular infections. Now, my question is, do you routinely do these surgeries under tourniquet? Thank you.
Do you routinely?
Do it under tourniquet.
If possible, yes, but for a shortest period of time. But yes, Whenever possible, we use tourniquet because then relineating things become easy. However, this is as regards infective things are concerned. As regards routine surgeries are concerned, we may or may not use tourniquet. But in this case, often we use tourniquet. But release it.
Thank you.
Generally release it before closure.
Thank you.
Dr. Gibran has a question. Good evening, Dr. Gibran.
Good
you can go ahead
evening.
with your question.
Good evening. Thank you. Thank you for the fellowship and presentations. Very interesting, and learned very much from your presentation, starting from day one. My question is a simple thing. When we are doing reaming of an intramedullary infection, do you use reamers to debride an intramedullary nails? What do you think about that? Would that be effective or not?
I will not like to answer this because there's a case with some queries on that. Case with questions. So I don't want to answer that. There's a case related to that.
Thank you. Then I'll wait for the case. Sir.
Yes, yes. Any other question? Any suggestions?
So I have one small doubt.
Yeah.
So
please mention your name so that people. Please mention your name. Sorry.
Sorry, sir. So this is Dr. Shashank.
Yeah.
I have a query. Like, do you prefer a synthetic bone graft or bone granules, cement granules, or normal bone graft?
In infected scenario, we would prefer normal bone graft. But there's so many conditions where one would use synthetic graft. But in this case, infected condition, it's best to use proper graft.
Thank you so much.
So if we are done. If there are any more questions, please do ask. We have 1 minute left.
Dr. Tarun Kumar has asked a question on the same thing. Can we use bone graft in infection? Will it undergo lysis?
When there is obvious infection, best not to use. Come back when you are absolutely sure that there is no infection, then put a graft. I do understand for TB spine, etc., many people do use a graft, but obviously first step is a good debridement and then go ahead and do a graft. But unless, especially in pyogenic, unless you are bang sure that there is no infection, avoid putting a graft because it will dissolve after a few days.
Generally, we would put it after 6 to 8 weeks after the antibiotic cover is over and then think of the reconstruction. Good evening, Dr. Avin. Dr. Avin has a question.
Good evening, sir. Sir, I would like to ask, can we go for a middle path regime kind of thing in a long bone fracture where we have initially debrided and then we can put an X-fix for, let's say, 3 to 4 weeks and then go for final procedure in the form of antibiotic nail or a simple nail? In that way, we can also address the issue of the minimal implant. And then we can address the stability later with the nail.
Generally, if you put external fixator for infected scenario, it is best to continue till fracture heals. If you, at all you put a fixator. If you think that your debridement is very good, you are, say in tibia, your debridement is very good, then you can as well go ahead with the antibiotic nail followed by a removal and appropriate nailing. Then there is no point in using external fixator for 3 to 4 weeks because that itself will increase the chances of infection when you take out after 4 weeks. So if at all, whenever you use a fixator in infected scenario, it is best to use it till end, preferably. In an open fracture, you may use it for a day or 2, 3, 4, 5, till the wound is very good And again, if you want to change it over to nail, do it within a week or 10 days. Don't do it. Avoid doing it at 4 months or after about 3 weeks or so.
Thank you, sir.
Hi, Dr. Kiran.
Hi.
Dr. Kiran has a question.
Good evening, I'm Dr. Kiran. Thank you for the excellent presentation, sir. My question is, do we go after every sinus tract that is there when we cannot include them in the incision that we are planning? Like there can be a multiple sinus and we cannot address all of them. So what do we do in that? And do they heal on their own after a thorough debridement is as per your experience, sir?
Generally, every sinus needs to be addressed because it's a potential source of infection and takes you somewhere. So every time, all the sinuses need to be excised. I agree that it may compromise the cover, but finally it will otherwise compromise the result. That very often happens in open fractures, very often happens in chronic osteomyelitis, more than commonly occurs in post-arthroscopy infection because all those 4 portals get infected. And then we will discuss about post-arthroscopy infection in subsequent time when how to address that. But yes, every active sinus needs excision of the sinus.
Thank you.
There's a question in the chat box by Dr. Srinivas Reddy, a preferred choice of antibiotics for beads. So I think we would be covering that in subsequent sessions. Antibiotic beads.
Yeah, correct.
So we'll keep that question for the next session, Dr. Srinivas. Milind Joshi sir has a question. Good evening, sir.
Good evening, sir. Sir, I just have one more doubt. Whenever we do a limb reconstruction and do a regenerate using Elizarov fixator, and in order to shorten the frame duration, most of them nowadays put LCP so that the fixator can be taken off. So what is the appropriate time? Whether see if I have kept the fixator for say 8 months, then after removing the fixator, I should wait for the sinus tracts to heal by about 2 to 3 weeks, and then I should go ahead with the surgery or of applying LCP, or I can directly put it. That's my question.
To be very honest, I am not comfortable with that technique. I would generally not do it.
Okay. Because I am equally scared of that. The frame is there for 6 months, and then, but I am seeing a major trend towards this.
I agree, but I have seen too many complications following that.
Okay.
So I personally feel that post external fixation, internal fixation carries its own risk.
Yeah.
To be used only when absolutely necessary. And then I would wait till these tracks are closed. Okay. I'll wait for at least 3 weeks. I'll not do it before that.
So you'll protect.
I'll definitely not do it at the time when I'm removing the fixator.
Okay, thank you.
The next question is on the chat box by Dr. Ganesh Singh. He's asked the antibiotic protocol in clean surgeries, whether for a few days or for a few weeks. So that also, sir, we would be covering in subsequent sessions because that's a talk in itself.
Because basically it would be a question to all of you, and we will also like to collect the data about your protocol. So at the moment, we don't want to discuss that. But yes, we would definitely cover it extensively.
Dr. Pankaj Sharma, good evening, Dr. Pankaj. He has a question. Please raise his hand.
Good evening, sir. Thank you for the excellent presentation. I would ask if there is a infected non-union distal tibia fracture, and the radiological and clinically we see the infection in the distal screw part and the proximal screw part, but the in-between area is clean, even clinically and radiologically. So should we open the skin in whole aspect or only remain confined to distal and proximal part only?
Absolutely right. Very good question. Go in for everything. If there is an infection proximally and distally, that means intervening part is infected. Do not take a chance of just making a small cut here, a small cut there, and you will burn your fingers. So open it.
Thank you, sir.
There's a question on chat box, I think.
Yeah, so there's a question on the role of methylene blue in debridement.
So I think, as I said, previous night you can inject methylene blue. The sinus tract gets colored blue and follow the track to the source of infection, and that becomes very, very useful. Do you put drains and what duration? Most of these infected situations need drainage because they keep bleeding. What is important is where to keep a drain. So the drain has to be in the line of incision. It should never be at an right angle to the incision, which is often done. You consider this to be a tumor. In tumor, what would you do? You will do a complete excision. Similarly, whenever you are doing a biopsy or whenever you're doing tumor surgery, the drain is always in the line of incision, because in case tumor recurs or in case infection recurs, then you can include the drain site into your incision and excise it in toto. So never put the drain at an angle, because you will have to include that area in your incision next time. How long? Totally depends on what case you are doing. If it is reasonably clean and there is not much drainage, you, like a routine thing, you take it out at 48 hours. But sometimes the discharge is significant. There is a huge cavity which needs filling up, and we have kept drainage for a longer time. Generally, keep it till the collection goes down below 20 or 30 cc per day. Otherwise, it would fill up again.
Next question is by Dr. Nilesh Nangre. So he said that there was a mention of amputation during the in the six-legged model. When do we decide and how do we explain it to the patient? Even if it's devastating, when should we plan for an amputation or explain that to the patient?
When? I think this is something we will have to keep discussing over next 4 or 5 turns. Really difficult to explain this, because we will discuss cases which would go in for amputation early and which will not go in for amputation early. A lot depends on the culture pattern, comorbidities, especially comorbidities. When patients have no comorbidities, you can take plenty of chances. But when patient has comorbidities, then you need to be very, very careful of extending treatment over months. The infection is not coming under control, then plan for an early amputation in patients with comorbidities. As I said, we will discuss this point, I think, in 4th or 5th module.
And one question by Dr. Nisha. Yeah, one question by Dr. Nishant. He is asked, in case of an infected case with external fixator in situ, should we consider an implant-free period? What should be the protocol of implant-free period? I'm assuming he means when to remove the fixator and put in an internal fixation.
Right. So if there is infection in presence of external fixator, then you need to address it first. That means the infection could be in the pin tracts, the infection could be at the fracture site. Correct? So when you have an external fixator and there's a pin tract infection, then if you want to continue with fixator, then you need to take out the pins, scrape the pin tracts, put the pin at another place and continue with the fixator. If there is an infection at the fracture site with the external fixator, don't even think of putting an internal fixation. First, excise the infection, get a good skin cover. Only when you are absolutely sure that there is no infection, and then you wish to shift over to internal fixation, then you take out your fixator, let the pin tract heal, and then address it accordingly. But in presence of infection with external fixator, avoid putting internal fixation.
I think that's answered all the questions on the chat box, and I don't see any raised hands. So what we've noted down all the questions that have not been answered, and you said we'll address them in the subsequent sessions, which we will do. In case some questions do get left out, Please feel free to ask those questions again. We have noted them, but we may miss a few. So you can always come back and ask us in the subsequent sessions. So I think, sir, we can wrap up the session, today's session. All the questions we can answer.
Thank you, sir.
So thank you all. We had a good time, I hope. See you next Saturday.
Thank you so much.
Just one small announcement. Are you all members of a society called WIOT?
No.
World Association
Not-
Against Infection in Orthopedics and Trauma. So I would suggest you can become a member. It's a free membership. Next Saturday, they have the conference. So maybe you can join if you become a member now, which would be quite useful. It is a